Hi, my name is Florence Ader. I'm an ID physician at the Lyon University Hospital in France, and I will present to you an overview of monoclonals treatments in the prevention and treatment of COVID-19. We all know this graph by now. After the initial exposure, patients typically develop symptoms within 5 or 6 days, which is the incubation period. And the viral load peaks in the first week of infection and declines thereafter gradually. In other words, the onset of symptoms is closely followed by the viral peak. The infection generates a large spectrum of clinical symptoms, ranging from mild infection to severe and critical disease, and possibly death. In patients with mild infection, host immune response can control viral load, leading to its decline. In severe and critical disease, the viral load can remain at high levels over time. On the host side, the antibody response gradually increases and is often detectable by day 14, which is an important milestone for controlling the infection. A recent work has analyzed humoral immune response in patients with asymptomatic, mild, moderate, and severe COVID-19 disease, eventually leading to death, over time, to probe the nature of antibody responses in disease severity and mortality. Results have shown that temporal dynamics is at play regarding neutralizing antibody production. Critically ill patients dying from COVID-19 have not a defect in neutralizing antibody production per se, but rather a delayed antibody production in comparison with high neutralizer patients and discharge patients. This suggests that an antiviral approach may still be relevant in the interval of still having high viral loads and not yet efficient antibody-mediated neutralization. Here are represented here the different phases of SARS-CoV-2 related states, including the prevention and management of the infection with SARS-CoV-2 and subsequent COVID-19. Basically, the prophylactic approach include the pre-exposure phase on the left-hand side of the slide and the post-exposure phase after a contact with an infected individual. Both phases are mostly ambulatory phases. Then the curative approach includes the PCR positive stages, going from the preemptive approach in which most patients are still ambulatory to the late disease approach in which patients are hospitalized. It is interesting to note that early phases are coupled with viral growth phase, during which antibody-mediated neutralization is relevant, and later likely is associated with an hyperinflammatory state in response to viral replication. Also, there is frequently an overlap between both phases. Passive immunotherapy mediated by monoclonal antibodies is a major player right now in the fight against COVID-19. To assess the use of this approach, randomized controlled trials have been conducted and or are currently conducted at all stages related to COVID-19, from prophylaxis to treatment in hospitalized patients. The primary efficacy outcome must be adapted to the setting and management. In the prophylaxis setting, the goal is primarily to avoid symptomatic disease and or hospitalization. In the curative setting, time to clinical improvement and death are the primary efficacy outcomes that are investigated. Here on that slide, the 5 main monoclonal antibodies that have been developed by different companies and under evaluation for the prevention and treatment of COVID-19. Most of them are a combination of two antibodies targeting non-overlapping target sites on the receptor binding domain of the viral spike protein, as previously explained by Brigitte Autran in the prior presentation. All these monoclonals can be infused by intravenous routes, but two combinations have been also evaluated either by a subcutaneous route or intramuscular route. Before reviewing the data regarding a randomized controlled trial testing mAbs treatment, let's focus briefly on the issue posed by the variants of interest and the variants of concern. When using mAbs, it is crucial to ensure a preserved antiviral activity on these variants which are emerging. And on the other hand, to monitor emerging viral strains under treatment, especially when using a single target monoclonal. For example, on that side, we can see the percentage of neutralization achieved by monoclonals treatments against some variants. As you can see, bamlanivimab do not neutralize the Delta variant, and 3 other mAbs are not effective in neutralizing the Beta variant, including the bamlanivimab. First, let's focus on the pre-exposure prophylaxis, for which we only have data from a press release and the publication is pending. Administrating mAbs on a regular basis is of interest in high-risk patients, such as elderly or immunocompromised patients, which have a poor response or no response to vaccination. The AZ firm has developed a long-acting antibody, which half-life is of 90 days on average, as assessed by the phase 1 study, indicating the residual protection exceeds 80% 6 months after infusion. In this randomized controlled trial, more than 5,000 patients received a single infusion of AZD7442 by intramuscular route or a placebo in a 2-to-1 randomization. Over the follow-up time, the risk of developing symptomatic COVID-19 was reduced by 77% and 83% at respectively 90 and 180 days. No cases of severe COVID-19 or COVID-19 related deaths was obtained in the AZD7442 group. The tolerance profile was acceptable. On that basis, AstraZeneca has sought an emergency use authorization from US and European regulators and other countries for this monoclonal. Let's move to the early post-exposure prophylaxis with, in this setting, 2 scenarios. Asymptomatic patients, but who still have a negative SARS-CoV-2 PCR, or asymptomatic patients who has converted a negative to a positive PCR. And here, the casirivimab and devimab cocktail has reached the primary endpoints in both situations with reduction of symptomatic COVID-19 when administered less than 4 days after exposure. However, AZD7442 did not meet the primary endpoint when the interval of administration was extended up to 8 days with a 1/3 decrease in symptomatic disease. Additionally, these pivotal studies report a lower viral peak in case of conversion to positive PCR and an acceleration of viral load decrease, As you can see on the right-hand side of the slide, there was a more rapid decline in viral load in the casirivimab and andivimab treated participants compared with those treated with placebo. The adjusted mean difference in viral load was minus 1.5 log per ml in favor of the antibody combination at day 8. The combination of monoclonals has also been tested in the setting of outpatients with mild to moderate COVID-19. These RCT have demonstrated a significant decrease in hospitalization and death for both monoclonal cocktails, bamlanivimab and plus itezivimab and casirivimab plus andivimab. However, as already acknowledged, there is a concern regarding the use of bamlanivimab and itezivimab against the Delta variant in a resulting in a monotherapy with an exposure to variant emergence under selective pressure. Based on these results, the emergency use authorization have been granted for both combinations, bamlanivimab plus itezivimab and casirivimab plus andivimab. Referring to what I previously explained as an expert opinion, I do not currently recommend the empirical use of bamlanivimab plus itezivimab, given that the Delta variant still massively dominates the epidemiological landscape of the pandemics. The two single neutralizing antibody have been tested as well in the setting of mild to moderate COVID-19 in the outpatient setting, with the report of positive results also a bit contrasted for the regdanivimab, which has not reached one of the endpoints of the composite efficacy outcome, namely the viral load decrease. However, clinical recovery was significantly faster. Based on these results, the European community has granted the marketing authorization for this monoclonal. The use of a single intravenous infusion of sotrovimab has also demonstrated an efficacy regarding the risk of hospitalization and subsequent death, which has led to grant an emergency use authorization in the US. And finally, several randomized control trials have been conducted in the hospitalization setting for severe COVID-19. Two sub-studies embedded in the ACTIV-3 master protocol promoted by the NIH, testing bamlanivimab and sotrovimab, have been stopped at the stage of interim analysis for futility. Quite an important result has been reported by the UK collaborative group Recovery, conducting the platform trial of the same name, which has tested the intravenous cocktail casirivimab plus andivimab at a high dose of 8 grams per day on hospitalized patients, most of them being documented at admission regarding the serological status. Although the primary endpoint of reduced mortality was not reached in the overall population, a significantly lower mortality was found in hospitalized seronegative patients in comparison with seropositive patients. And here on that slide, you have the graph of this important result, since it is the first study that has demonstrated a benefit in mortality rate using an antiviral treatment in a subset of patients that have not mounted a humoral response and that have a severe COVID-19, requiring hospitalization and for most of them, oxygen support. In a way, this connects with the data reported earlier in the presentation by the Iwasaki group at Yale regarding the delayed antibody production in patients with the poorest outcome. Other randomized control trials are currently evaluating another monoclonals, AZD7442, in hospitalized patients with COVID-19, still within the Active 3 master protocol and within the pan-European EU response discovery protocol. And this is a summary of the monoclonal treatment tested at the preventive and curative phases of COVID-19. A majority of the randomized control trials have been conducted in the preemptive or early disease treatment phase and in the community setting. This is probably the optimal window of use for the monoclonals in the treatment of COVID-19, in the prevention and treatment of COVID-19. As a conclusion, monoclonal antibody were the first game changer in the antiviral field. Results are expected for a COVID-19 hospitalized patient with AZD7442. A constant vigilance must be applied for the emergence of variants of interest or of concern. What is next in the treatment approach of COVID-19? First, the pre-exposure setting with long-acting antibody in high-risk patients refractory to vaccination is a very relevant and interesting approach. Second, the combination with new antivirals, namely protease inhibitor or RNA mutation promoter, is a very interesting track to combine a therapeutic approach in patients with COVID-19 or that have been exposed to COVID-19. And lastly, randomized control trial focusing on high-risk subgroups of patients would be very useful to, I would say, having a granular approach on the best treatment options and best monoclonals for different subsets of patients. Thank you for your attention, and I am available for questions.